Alright guys, welcome back to another episode of the ICU curriculum. Today we're going to be talking about Ards. Just another quick reminder, these episodes are designed to be short little summaries, kind of concise reviews of some of these topics, and they're designed to complement bedside teaching. So without further ado, let's get going. We're just going to start with the case today. I'm going to read it out. You can read it yourself. This is a 29-year-old female who is morbidly obese, and she presented to her local ED with some dyspnea, cough, and fevers. She has several sick contacts with influenza. Her initial labs demonstrated that she was tachycardic with normal blood pressure, SATs are 75% on room air. She's put on oxygen. She ultimately deteriorates over the next couple of hours and ultimately requires intubation secondary to this hypoxia. She becomes difficult to oxygenate. You can see here she requires very high ventilator settings, 100% FI2 and PEEP of 15. Her chest x-ray looks as follows. Alright. I would describe this basically as bilateral patchy airspace disease. It's in the upper and lower lung fields. So what does she have? She has ARDS. Now, ARDS it's interesting. This is a syndrome. It was first described in 1967. And up until 2012, we were using the AECC definition. And then in 2012, it was replaced by the Berlin definition. And the reason was because the AECC definition had a couple of issues. The time course for the disease was not well defined. There's this confusing terminology of acute lung injury versus ARDS. There was also, well, you can see here, poor inter-observer chest x-ray interpretations. And the other interesting thing was in the previous definitions, there was a very specific distinction made between you could not have congestive heart failure and ARDS kind of at the same time, when the reality is we all know people can be volume overloaded and have ARDS as well. They also never really discussed formal risk factors for ARDS. So, the Berlin definitions in 2012, you can read here. I'm not going to go into super intense detail, but you can see here the timing is 1 week to the symptoms. Chest imaging demonstrates bilateral opacities not explained by something else. The origin of the edema is not fully, this is a good distinction, this is not fully explained by cardiac failure or volume overload. So you can have concomitant volume overload and ARDS, but to have ARDS, you can't. You just want to make sure that the airspace disease is not from the heart failure only. They give you this little categorization of mild, moderate, severe, depending on the P to F ratio. That's the PO2 to FiO2 ratio. So you can see here, 200 to 300 is mild, 100 to 200 is moderate, and less than 100, a P to F ratio of less than 100 is in the severe category. This is important because the mortality in severe ARDS, you can see here, is approaching, it's almost 50% here. So it is a very serious life-threatening condition. These are some of the risk factors. You can just look at that. You can pause it if you want to. So the physiology. There are a couple different phases to ARDS. When you see them, when people present, they're usually in the exudative phase. You can read here, that's where you have fluid protein and inflammatory cells leaving the alveolar capillaries. They're accumulating in the airspace, which results in hypoxia from poor lung compliance and VQ mismatch. Then there is a second fibroproliferative phase. This is where we go kind of from an acute to more of a chronic inflammation, which causes connective tissue proliferation and can cause pulmonary fibrosis. There's another recovery phase, and ideally you would like to see this happen quickly, but sometimes it can take 6 months to a year before people really get better. I've always liked this picture. It's from a New England Journal of Medicine review article. It kind of gives you a good demonstration of what a normal alveolus versus a alveolus who is in the acute phases of ARDS. The changes that are going on there. So what you see is this is the normal alveolus over here, capillary. This is the interstitium, and this is the actual air sac. That's the alveolus right there. And then on the right, you see that there's neutrophilic inflammation here inside the alveolus, so it's filling up with basically inflammatory cells. There's actually fluid that is leaking out in between the capillary and the alveolus, also further distancing these two, making it harder for gas exchange to occur. There's impaired removal of this edema, and there's also a reduced production of surfactant as well. This is another diagram here that kind of gives you an idea on some of the phases, the chronicity of the phases. You can see here in this exudative phase that we've talked about, you have edema and the hyaline membranization occurring kind of in the first week or so, and then after that first 7 to 10 days, you start to see it transition to the proliferative phase where you actually start to get chronic inflammation and the fibrosis that we discussed earlier. So at this point, we're going to talk about some of the different studies, kind of the landmark studies that have occurred over time. that have shaped the way that we treat ARDS and the way that we understand it. So the first one we're going to talk about is the ARMA study in 2000. There's a little citation down here if you'd like to look it up after. This was basically a study across this ARDS network. The Ards net is kind of how you hear it referred to. So it was 861 patients, and in this study they were looking at comparing low tidal volume ventilation, so 6 milliliters per kilogram, as compared to what was kind of conventional wisdom at the time, 12 milliliters per kilogram of tidal volume. So the outcomes, you can see here mortality, number of days on the ventilator, and interestingly enough, the study demonstrated that the mortality was much lower in the low tidal volume group. You can see here almost 31 to 40%, as was the decreased number of days without the ventilator. The teaching point here for this study was that this shifted us to focus more on this low tidal volume ventilation, where we target 5 to 7 milliliters per kilogram of ideal body weight, and we kind of allow the CO2 to drift up as a result of that, and the pH to drift a little bit lower as a result. So typically, if someone has a pH of 7.20 and above, we allow some degree of hypercapnia, to kind of maintain this low tidal volume protective lung ventilation. This is the alveoli study. Again, 2004, across that same network, the Ards net group. So this was looking at comparing Ards as treated with a high versus a lower level of PEEPs. We're going to show you a chart in a second to kind of get an idea on what those two different leukologicals look at now. So this is kind of the idea here. You're looking at a group that if you look at the PEEP really kind of stays, I will say, lower. So when you're on, say, 80% FiO2, your PEEP is around 14. Whereas you look at this group down here, the PEEP really dramatically increases early on, and by the time you're up to 80%, you're already up to a PEEP of 22. So they looked at outcomes again, the same type of outcomes: mortality before discharge, number of days in the ventilator, and what they found was that the clinical outcomes were pretty similar in the two groups, which again has kind of shifted the focus towards maybe not using, kind of reserving those really, really, really high PEEPs for maybe the sickest patients, if ever, due to the risk of barotrauma and pneumothorax, because ideally you want to target this plateau pressure of 30 centimeters of water, and that gets a little difficult when you're already on 26 centimeters of or 24 centimeters of water pressure from your PEEP here. Okay, so moving on, we're talking about the FACT study. This is a kind of a complicated study because there were two different parts to it. There was two arms. This was 1,000 patients across North American ICUs, and they compared, in one arm of this, they compared the PA catheters versus just using central venous catheters for the management of ARDS, and it was also, we talked about the second part, where they looked at conservative versus liberal fluid management. So this is a little complicated. Two studies kind of rolled into one. So as far as the PA catheter, pulmonary artery or Swan-Ganz catheter study, these are the outcomes they looked at. And here, the results are interesting. There was no significant improvement in mortality or organ function in groups that were using the more invasive PA-guided, or Swan-Ganz catheter group, as compared to just a regular central venous catheter-guided therapy group. And the other comment that was made was that there were more complications in the PA catheter group as well. Now, there's a little caveat here because, in the study, the complications were mostly arrhythmias, and it's kind of the way they designed the study, that if you were getting a PA catheter placed, you were basically in the ICU with constant telemetry, so they were able to kind of really identify those arrhythmias, where a lot of times people that had central venous catheters had those done kind of prior to randomization or at randomization, so they were placed without telemetry. So that's just one little caveat. There were more arrhythmias in the PA catheter group, although they were probably a little scrutinized a little bit more as well. But this has kind of led people to at least say, okay, surely we shouldn't use PA catheters in everybody, because it's clearly demonstrated that there's no improved mortality when you compare using PA catheters versus not using PA catheters. So this is the second part of the FACT study, and we're going to show you a little chart here in a minute that might make things a little more clear. But in this study, they looked at the same type of endpoints for the fluid study: mortality at 60 days, ventilator-free days, organ failure-free days, and then measurements of lung physiology. And what they found was interesting. So when they compared conservative versus liberal, I guess, fluid resuscitation, they found no significant change in the 60-day mortality using the conservative group. But there was an improvement in lung function, shortened duration of mechanical, like less days on the ventilator and less days in the ICU in the conservative fluid strategy group. So this next chart is a little complicated, and I want to quickly go over it here. So when they randomized patients in this study, what they did was they randomized patients. They basically assigned them to a little kind of like a therapy. They call them cells, a little group over here. So they got basically a number 1 through 20. And the way they figured out which group they fell into was they looked at a couple of things. They looked at either their central venous pressure or their wedge pressure, depending on which group they were in. They looked at their blood pressure. Were they less than 60 or were they greater than 60? And they looked at their urine output. Were they less than 0.5 milliliters per kilogram per hour or were they more than that? And then they, again, categorized them. Are they in ineffective circulation or effective circulation? So were they someone who had a cardiac index less than 2.5 if they had a SWAN? Or were they someone who had cold mottled skin with poor capillary refill if they didn't have a SWAN? And that's how they came up with a number, 1 through 20, and they were able to determine what therapy should they give them in this study. And they just kind of looked at those different groups to see how they did. So probably the most important group to think about would be in someone who has ARDS, who is kind of in that recovery phase. So we're going to say their their blood pressure is okay, it's greater than 60, so they're over here. Their urine output is greater than 0.5 milliliters per kilogram per hour, so they're doing well. And they have effective circulation, so their cardiac output isn't an issue. Then the question is let's look at these different groups. What if they had a CVP of 8? So if you look at that over here, if let's just say their CVP was 8, they might fall into the group 18 or group 19, depending on if they're conservative or liberal. So in the conservative fluid balance group, if you looked like you're doing well, blood pressure's fine, urine output's fine, effective circulation, but your CVP was 8, they would actually recommend giving Lasix to kind of diurese that person here. Versus in the liberal group, you might think about giving fluid boluses because their CVP is low. Because you can see here, we're talking about these two groups, 8 and 10 here. So this is the distinction. Should you resuscitate for that CVP being less than 8, or should you maybe give some diuretics? And what they found was that, in this group here that got diuretics, well, they didn't live, their mortality wasn't different, but they came off the ventilator a little bit sooner, got out of the ICU a little bit sooner, and they had better lung function. So this is kind of the teaching point, I guess I would say, for this study, is that in general, we would like to, if it's possible, run people a little dry if they have ARDS. And you want to definitely avoid adding an extra problem by giving them too much fluid and causing also volume overload. I think that generally kind of makes sense. This is another study here where they looked at, this is a steroid study, where they looked at 180 patients across this Ards network, and they compared the use of methylpred versus placebo in patient who had Ards at least 7 days duration. And they looked at, kind of the general outcomes you'd expect: 60-day mortality, all the other numbers of days on the ventilator, organ failure-free days. And what they found was that there is no significant difference in mortality at 60 days or 180 days in the methylpred group. Now, when they went back and looked, they did notice that methylprednisolone use was associated with an increased mortality at both 60 and 180 days in patients who were enrolled in the study 14 days after the onset of ARDS. So when we kind of thought back to that chart from before, when we kind of put people in categories, are you in the exudative or are you in the fibroproliferative phase, it seems like, based on this study, people who are already in that fibroproliferative phase, when they got put on steroids, well, not only did it not help, but it actually made things worse. And there's lots of postulation, theories as to why that would be. Maybe it has to do with neuromuscular weakness. You can see on here, the methylpred, it was associated with increased number of ventilator-free and shock-free days, respiratory compliance, less vasopressor use, but it was also associated with a higher neuromuscular weakness. So maybe, if you're using steroids later on, you're kind of getting some of those bad effects, such as the neuromuscular weakness, and it's maybe a little bit too late to get some of the potentially theoretical helpful effects. So, in general, most people, if they use steroids for ARDS, which is, again, always just going to be controversial, most people, I would say, avoid doing it late. So we won't you don't typically see it started late in the course of ARDS. This is another study. This is kind of interesting. This came out a little bit more recently. This is a French study that looked at neuromuscular blockade in patients with ARDS. 340 patients were randomized in some French ICUs. They compared the use of cystatricurium, or Nimbex is what it's its trade name, versus just placebo in patients who presented to ICU with severe ARDS. Now this is the key here, within 48 hours. So this was an early treatment study. You can see some of the outcomes there. And what they found was that there was a 90-day mortality. It was actually improved in the cystatricurium versus the placebo group. So this is kind of interesting because normally, well, I say normally, oftentimes when we use paralytics in the ICU, you'll see us targeting a specific level of paralysis with something we call a train of 4. That's where you give the patient a number of shocks to see how paralyzed they are. And they didn't do that in this study. They basically gave people a flat dose, I think it was 15 milligrams of Nimbex, and then they put them on a drip that was at a set rate for that 48 hours, and that was it. There was a caveat in the study, if someone's plateau pressures were very, very elevated, either group could get a one-time dose of cystatricurium to see if it helped. But for the most part, there was no titrating. It was basically you got hit with a bolus and a drip of Nimbex, and whatever happens, happens. Which is just different because that's not traditionally how it's used, across all ICUs. But again, there was a mortality benefit. So you've kind of seen Nimbex or cystatricurium becoming a little bit more in vogue over the last maybe 3 years since this study came out. I'm sorry, 6 years ago. Okay, moving on. This is another study that came out in 2015, so this is, again, kind of more recent. And this was looking at high-flow nasal cannula versus other modalities for the treatment of ARDS. Again, a French study. The outcomes were number of patients intubated at 28 days, all-cause ICU mortality, 90-day mortality, ventilator-free days. And again, they were comparing both high flow to face mask and BiPAP, or non-invasive positive pressure ventilation. So this is interesting. In this study, they found, I only put a couple of the results down here just because there's a lot, but they found that the intubation rates were actually better in the high flow nasal cannula group versus the face mask and BiPAP groups. There was a similar trend in the ventilator-free days and even in the 90-day mortality. The 90-day mortality was statistically better in the high flow group compared to the other groups. Just kind of making you think maybe we should use that as the initial treatment for ARDS in patients who have not quite progressed to the point where they look like they need to be intubated. And maybe we should avoid things like BiPAP in the treatment of ARDS. If they need to be intubated, if they need ventilation, maybe it should be invasive as opposed to non-invasive. But okay, so this last slide is kind of a too long, didn't read summary slide here of what we just talked about. So in regards to mechanical ventilation, general consensus is you target 5 to 7 cc's per kilogram of ideal body weight. This is kind of, I guess you'd say, industry standard. You want to target low plateau pressures of at least less than 30 centimeters of water pressure. Permissive hypercapnia is acceptable. So if someone's pH is running 7.20 with a PCO2 of 60, you're fine with that in severe ARDS. The high PEEP, if it's used at all, is reserved for severe ARDS. You kind of want to target in general, a conservative fluid balance. You don't want to give yourself another problem by adding volume overload. You can consider using paralysis in patients that come in with severe ARDS if you're in that kind of early phase, less than 48 hours from symptom initiation. And steroids are always going to be controversial. You probably want to avoid them if the patient, in that late phase, in that fibroproliferative greater than 14 days of onset of ARDS. Hopefully this talk has given you guys some insight into how and why we treat ARDS the way that we do, and has generated some topics of conversation for you guys to talk with your attendings when you're out on rounds. So good luck out there, guys. Take care.